All right. Well, now it's really my pleasure to introduce someone I think most of you know pretty well, my co-director, Dr. Oliver Freudenreich. I think maybe many of you know that Dr. Freudenreich is also one of these, multi-talented, amazing person who has, been a dedicated and incredibly beloved clinician for decades, also internationally recognized expert in the treatment of schizophrenia, amazing teacher of, award-winning in multiple settings for his teaching. And yeah, you all may not know that Dr. Freudenreich gives lectures all over the country, all over the world on the pharmacology, the treatment of psychotic illness. So I'm really looking forward to this talk because I know I'm going to learn some things about the latest developments in this area. So, thanks.
Thank you, Daphne. That was very generous what you said. I'm internationally known simply because I have a fake German accent. So if you're harsh on me, I'm going to just talk right back with a German accent. Let me just say, though, it's hard. After this, it is moving. For me as a clinician, this makes it real. It really brings back, why I'm doing this. Yes, I do travel, and so I have benefits from my job and being at MGH. I get it, but in the end, this makes it all worthwhile to hear these stories. And yes, I understand that some people here, they hear these stories and think, why is my child not, as successful as those people? But I think what they all told you is it's a journey. It doesn't happen overnight, and who knows what it is in the end that makes a difference. It seems critical that there's some form of support, right? Family really seems to matter greatly if family is involved. But then you also learned that one of the panelists, she's here by herself with her husband and a child. Lives can be difficult. It's very humbling to hear this. I'm going to talk about new drug development, and I'm going to show you here my disclosures. Why do I do this? Because I think it's the right thing to do. I do work with companies who do drug development. I'm in an academic setting. I actually fundamentally believe it's important to continue to improve the drugs that we do help to figure out new ways of treating the disease. So yes, I'm talking about medicines today, but I also want to say I'm the last one to say, psychosocial treatments are not important, social support is not important, what the state does is not important. And yet it is a critical piece of treatment to have effective medications, I believe. And the medications that we do have today, many of them are somewhat effective, some are really very effective for selected people. But broadly speaking, we would like to have better medicines, and we would like to have medicines that are better tolerated. A lot of you will know taking these medicines that we have are not easy. There's sedation, there's weight gain, all kinds of problems. If you asked me, would I volunteer, and they used to do this in medical school, to take the medicines that I prescribe, just a dose or so? I have to say I'm not so sure. If given the choice between trying an antipsychotic or a benzodiazepine like Valium or something, I would always go for the Valium and not for the antipsychotic, because I do know, there might be some unpleasantness. So it's in this spirit that I'm talking about drug development is a really important aspect, I think, of what I do in addition to treating patients and giving talks. Let's just step back conceptually and think, what is actually a good outcome in psychiatry? And yes, I understand that down the road, it's not complicated. People want to have good lives. They want to be able to do the things that they love doing. They want to have a good job that they enjoy. They want to have safe incomes. They want to have families. So if you have a psychiatric illness, your wishes for your future are not different than my wish for my future. But we can be a little bit more precise when we speak about drug development and think about, well, what are the unmet needs I cannot with the medicine, with a pill, I'm not going to give somebody a job back. That's a societal function to some extent. On the other hand, with medicines, I need to put people in a position to actually be able to work and get a job back. So here, if we think about schizophrenia as a syndrome with dimensions, there's not just one thing, but we can look at various aspects of having schizophrenia. And there's different problems for different people and different admixtures of these problems. So we have people who have positive symptoms, delusions and hallucinations. And if you're lucky, you take medicines, you have none of those. Medicine works perfect for that. There's a large group of patients, though, where they work some, the medicines, or not at all. So there's a huge need to find treatments that address these very vexing and problematic and painful experiences of having incessant hallucinations. Hearing something that constantly going on and on and on about how bad you're doing, for example, you can't shut it off. The Adavar therapy was one non-medication attempt to address this problem. Prominent negative symptoms. For a lot of patients, even if they have no positive symptoms, they struggle. They struggle to be motivated, they struggle to get out of bed, to figure out what to do next. And it's not ill will, it's not laziness, it's part of the illness. And we desperately need medicines to help with that. Because think about it, it's a catch-22. There's part of an illness that doesn't allow you to do things. And the very thing that would be best for you to do things, you cannot do. So a medicine would be really helpful to jumpstart kind of your system so that you end up being able to do the things that we want you to do. Neurocognitive impairment, memory problems organizing your days. It's a big, big unmet need. We have no medicine for this at this point. And now related on the other side to those aspects of treatment where we have treatment, but it's ripe with side effects, weight gain, and extra. I should have put here something more simple, like movement disorders, like tardive dyskinesia. You might have heard. So there's some issues with the long-term taking these medicines in the long run, where we I think need to dedicate significant resources to find better treatments. And then the last point is relapse prevention. Maybe there are some ways to actually find ways to give these medicines in a way to prevent the one thing that I think is a disaster, which is the second or third or fourth or fifth episode of having an illness. Each time you're in an episode, you're going to be out of commission. And it's this accrued the accrued social toxicity, as I call it, over time. That's actually the crux of the illness. So I spend a little bit more time on this. I'm going to, for some slides, I'm just going to give you some ideas because you have them, so you can go back and look and get more interested in it if you want. But I think it's actually important to outline a little bit more detail why it is that drug development matters, because we still have a syndrome where a lot of times we don't really have the treatment that we would love to have. We don't have the treatment with regards to efficacy and with regards to tolerability. So there's a huge need here. So let's start with symptoms first. I'm going to put this just up there as number one, lumateperone, because this drug was submitted to the FDA, which means this is probably, unless there's a surprise, this is probably going to be the next antipsychotic that's going to be approved. There can always be a surprise, and the medicine might get rejected. But all this slide shows you basically the drug company did a lot of work. They did the typical trials that you need for drug approval, and it seems to be that this drug is working. We'll have to see, is it just another Me Too drug? And there's reasons to think it might not be based on the receptors, but we'll have to see if it's a better drug or not. Okay, so this is just the one I put up there because this might be the next one that actually comes to market. Let me also just say something, because I put some mechanism of action here. I put some, receptors. The company actually made this term up, dopamine receptor phosphoprotein modulator, because it sounds great, right? Oh, a DPPM. The problem with drug development is, and this drug exemplifies this, I'm telling you, they did the typical trial to show it's going to work, but we don't really know why. It's we at this point in the field, because we don't know the mechanism of schizophrenia. I cannot draw a map here that goes from A to B to C to D. You know, kind of the things that we know how diabetes develops. We don't really know this. It's called pathophysiology. We don't know this with schizophrenia. It's really hard to develop treatments if you don't know the pathophysiology. So the companies will always emphasize a particular combination of receptors in their materials. Say, oh, this is why this drug is better than the other drug. But the honest assessment is we don't know. And it's an enormous risk for companies. If you think about it, we have hundreds of receptors and receptor combinations, and they in the end have to bet on one compound, that somehow this one compound is going to make it. And you know, of course, they have animal studies and all kinds of evidence why it might make sense to think this is going to work. But it is actually a huge gamble that companies are taking as well. And I'll show you at the end that the graveyard, you know, of drug development is pretty significant. Don't want to spend too much time on this. Just want to point out that there is this ongoing effort to develop drugs, including for positive symptoms, that do not affect the dopamine system, which is pretty much where all drug development is at this point in time. So the excitement of the cannabis system is in part not because it's cool, we're doing something good here by taking, an addictive substance. But as you heard, it's actually complicated, right? There's the THC part, and then there's this other part. So we'll have to see if this pans out or not. It would be of interest because it would target a system that is not the dopamine system. At this point, we have no drug that does not also in some ways affect the dopamine system. Why does this matter? It matters because on the one hand, we do need to shut down dopamine. That's the one thing we believe to be true. In psychosis, broadly speaking, you have too much dopamine. You have to shut it down. On the other hand, dopamine is also incredibly important for us to feel well, to be motivated. So we have a problem. We're on the one hand doing the right thing by shutting down dopamine. On the other hand, we have a problem. We're also going to maybe shut it down too much. And that ties into negative symptoms. So we have a treatment that might make some aspects of the illness actually worse. So here what this shows is I put the antipsychotics very small here. You see positive symptoms. In the big scheme of things, it's actually not the positive symptoms. I mean, there's always exceptions. Somebody has unremitting hallucinations, as I said. But fundamentally, we actually have treatment with the dopamine blockade that work reasonably well. But the negative symptoms and the cognitive impairment is what gets in the way of people being successful. You can be doing a job and have a little bit of voices, and most, actually a lot of patients that I know have this occasionally a little bit. That's not the thing that gets in the way of living your life the way you want. It's the negative symptoms, the problem with motivation, and the cognitive impairment that unfortunately for many people is part of this syndrome of schizophrenia. So there might be differences with available drugs with regards to what I just said, how we affect the dopamine system. Cariprazine is actually, Vraylar is the brand name, is actually an approved medicine that you could ask your doctor to try. And your doctor might have reasons to say no, why this shouldn't be tried. But this is a drug that affects the dopamine in a way, and I put this here as a D2/3 partial agonist. All this basically says it doesn't shut down dopamine completely. It shuts down if there's too much dopamine so that you're not psychotic, but it allows kind of natural dopamine release. And the idea is that it's probably better than for motivational systems and negative symptoms. And the company, actually this is a very prestigious journal, The Lancet, has published a clinical trial where they showed on the left, if you take cariprazine compared to on the right, the green one, if you can compare, if in this case it was risperidone, which blocks D2 100%, your negative symptoms look a little bit better. Now, is this clinically relevant for most people? These are group means, I don't know. In individual patients, it might actually really make a difference.
Is the caprazine, are you saying that's Vraylar?
Yes. Yep. For the sake of to acknowledge Josh, L-methylfolate, it's one possibility to add on. He has done good work in showing there might be a small role for that. Roloperidone I put up there because that is also a drug that might at some point come to market, and it does show that companies do recognize that we need better drugs for the negative symptoms. So this is a whole drug development program attempting to really improve negative symptoms as opposed to just looking at psychosis. As you can see, I put at the top here 5-HT2A and sigma-2 receptor antagonist. What does it mean? It's yet another attempt to say, well, we haven't tried this combination yet, and there's animal models to suggest this might be a good combination to try. It's extremely risky to bet on this, but at this point, there were some positive early trials, enough to suggest that a phase 3 trial is that trial, or the 2 trials that are needed to get FDA approval, that the companies initiated that. So just as an example of ongoing work in negative symptoms. The elephant in the room is exercise, okay? Even though I speak about drug development, but here's something. It actually applies to all of us, not just for those of us with an illness. CIS stands for cognitive impairment associated with schizophrenia, so cognition. Well, it turns out that exercise is actually really good for you. What a surprise, right? What a surprise. It's neuroprotective. We can actually show that parts of your brain, if you exercise, important parts that have to do with memory actually get bigger, Looks impressive, at least when you see it on a scan. Has broad effects on well-being. It improves global cognition. And it really affects key pathways of inflammation and other important agents in the brain that do the right things. So there's no secret here that exercise would be really good, not just for us, but also particularly for people who have problems with cognition to begin with. And at this point, we're trying, there's such a thing as supported exercise, where you don't just tell people, go ahead and exercise. When has that ever worked, right? But maybe, go with a family member, and then it becomes part of what they do, and they put it on a calendar. So this is the supported piece. The real problem is to have people sustain it, as you can imagine. We all go at starting something, and then we fail to sustain it. And I want to point out that why is it so difficult for our patients? Because in order to start and sustain exercise, you need those brain functions like being motivated and being persistent that are actually the core of the illness. Okay? So, and I say this because I want to defend some of my patients, where I think all they ever hear is you don't want to do something. Well, it's not for lack of not wanting. It's more often not actually for being unable to do it. Tolerability. This is my daughter's harmonica, made in Germany, as you can see. It reminds me of something really important, that I fail if my patients die from medical causes. If I keep them well psychologically and then they die from medical causes. And unfortunately, many of our medicines come at a high price for patients. Ask them. Weight gain, diabetes, which is then a risk factor for cardiovascular disease. So this is a person I saw in our clozapine clinic for many, many years. He always came in, played the harmonica for everybody. You always knew he was there. Only knew one song, but he played it well. And he would laugh hearing me say this, if you could hear me, because one day the harmonica stopped. He had died from a heart attack. So it's actually incredibly important to not just focus on developing medicines that work, that's called efficacy on the symptoms, but also medicines that are safe. Because those medicines, for many, many patients, are going to be taken in the long run. It's not just a one-time thing, a month or so. It's years and years and years. I'm involved at a supervisory level in this trial, MELT. This uses actually approved medicines, lacosarin and metformin. The brand name for lacosarin is Belvic. It's an appetite suppressant. So sometimes as a field, I think we just have to be a little bit more aggressive in actually trying to understand, if we could use existing treatments, can we help people? So this trial is trying to decide if we add those medical treatments onto people who need to take something that causes weight gain, do they actually do better or not? And I say this because sometimes, including myself, we're too conservative. I think we're just saying, oh, wait and see, we need more research. More research, and a decade goes by, and my patient has gained 20 pounds, right? So this is one example of efforts in this regard. Liraglutide is not a medicine I would prescribe. It's a diabetes medicine, although it's actually approved also for people who are overweight. But it's just one example of using existing treatments and studying them in our patient population, and at some point, hopefully, to have a really combined effort together with medicine to keep the patients that we see in psychiatry, to keep them well, including in this case, this is something that basically a diabetologist or an internist would use. I wouldn't be comfortable using this. It's outside my area of expertise, and yet I feel it's incredibly important that we have a treatment system where I can work with somebody who would be comfortable using this in our patients, because many internists are not that comfortable with working with our patient population. And often if we use something like this in a preventive fashion, they would say, well, your patient doesn't have diabetes, I'm not going to prescribe it. And here I would say, I want you to prescribe it in a preventive fashion. So that's why at this point there's also research with medicines that are outside the area of psychiatry. Tardive dyskinesia, tardive dyskinesia is an abnormal movement disorder that has not gone away. It remains a threat to anybody who takes antipsychotics. There are now 2 approved medicines approved last year for tardive dyskinesia. There had been none prior to 2017. Deuterated and valbenazine. As you can maybe see by how these names end, they're derivatives of tetrabenazine, which is a drug that's approved for Huntington's disease. Very difficult to use, difficult issues tolerating it. So the 2 companies have actually spent money to try to improve on that drug. And I don't want to belabor the point, but just one thing I think, because it's really cool, the idea of deuterated medicines. What are those? Well, the deuterabenazine is actually the first FDA medicine based on this deuteration principles I explained that has come to market. So psychiatry is actually number 1 here. What is it? The hydrogen, you might remember from chemistry, has three isotopes: hydrogen, deuterium, and tritium. So don't want to go into big details about it, but if you take the hydrogen out of molecules and replace it with deuterium, it's a little bit heavier, okay, just in terms of atomic weight. You strengthen this bond between the carbon atom and the hydrogen or deuterium atom, and it makes it harder for your body to actually metabolize, to get rid of this compound. So by doing this, you increase the half-life of drugs, which means you can bring drugs to market that instead of having to take it 3 or 4 times a day, you have to take it once or twice a day. This is a huge area of drug development now because a lot of drugs are complicated to take, and not just in psychiatry. And it's not simple, but it's one way to increase the half-life of drugs. So that's what they did with tetrabenazine, to increase the half-life of this drug. It's cool because you don't change the characteristics of this drug because the 3D structure remains exactly the same. So you attach to the receptors and do all the kind of things that you want the drug to do exactly the same way. It's just the way the body gets rid of the drug that's altered. And the other slide I want to show you is because I'm so proud of this slide, which I produced. Took me 2 evenings. Valbenazine is a very complicated drug in terms of metabolism. It ends up being a fairly pure metabolite of tetrabenazine, if you will. That I don't want to go into details about it. But there's now two choices, basically, if it's paid for. These drugs are incredibly, people are laughing here. These drugs are incredibly expensive at this point. They do work, by the way. If you have somebody with tardive dyskinesia, these drugs absolutely work. Yeah. Relapse prevention. What is the big problem? I already alluded to this. I want to repeat it here. The big problem is, I think the core feature of many of our disorders in psychiatry is that these are recurrent illnesses that come and go with accrued disability over time. Each time you get sick, you lose something. You lose a job, you lose a friend, you lose your reputation, and it adds up. And after 5, 6, 7 hospitalizations, you find yourself alone at home, isolated, your friends don't call you anymore, you've lost your job. All of which could have been, maybe I'm too optimistic, but if you think about it just logically, could have been avoided had there not been these series of relapses. So a lot of effort has gone into developing preparations of drugs that we do have to make them longer acting. It's a huge list. It's small. I don't want to go into this. You're not the one prescribing those. There is a huge choice now of so-called long-acting injectables, not just for the old medicines, the Haldol Dex and the Prolixin Dex that you might recognize, but for many of the newer medicines, there's also long-acting injectable preparations out there. Some is to take as infrequently as every 3 months, and there's actually companies are trying to develop drugs that have to be taken even less frequently. One I want to point out, because it is a new one on the market, I've not used it myself. It's a drug that I want to highlight here. It's going to be taken or can be taken subcutaneously, just like insulin. And maybe that for some people is actually something that they feel more comfortable doing. I believe there's actually something that family members might be able to do easily, So there might be a small role for a drug that is supposed to IM, intramuscularly, which is how these drugs are taken, to be given subcutaneously. Time will tell. Now, Hannah already talked about technological solutions. So this idea of digital medicine for adherence monitoring. Not really drug development, but in some ways it is, because these things hang together, right? So we have new acronyms, which is great. IEM, ingestible event marker, DMS, digital medicine system, you name it, It's going to be a test afterwards for all these acronyms. How does this fundamentally work? Well, you take a pill that actually has a sensor embedded in it, then that sensor gets activated when it hits the gastric acid, the stomach acid. You wear a patch that picks up on the signal, and then that signal gets sent to an app on a cell phone, and then it gets uploaded in the cloud, where the government will have access then. I just want to be a little bit critical about this. Not because I don't think it's the future, it clearly is, but there are unresolved issues, and we don't want to oversell this at this point. Does it actually improve adherence in real patients with psychosis, both in the short and the long run? We don't know. What is approved at this point is actually, because there is a pill approved, aripiprazole, that has a sensor in it, and the whole system around it. It's not approved because it works better for adherence. It's only, the company only had to show that patients can use the system. Okay, it's a big difference. It doesn't actually show that it works better than working with patients on their adherence. And I do have to question, will the average patient with a serious illness, not the high-functioning ones, the loves who wants to, but the average patients, will they actually really be able to use the technology? And like in medicine, always you want to look at, patient selection. I think clearly this is not going to work for all patients. Are there risks of digital adherence monitoring? We already alluded to this in the discussion. I just wanted to ask, is technological solutions always progress? Is there a downside? I think the biggest issue, other than medical privacy, obviously, increasing health disparities. Are we just going to use this for particular patients, the ones who either can afford it or the ones who are disadvantaged to begin with. You know, we're going to have the state control them even better, you know. But does technology replace meaningful other interventions, including human contact? That is I don't have the answer to that, but that is the concern that I have a little bit. Who is actually going to spend time with patients who are non-adherent to find out why it is that they are non-adherent, if we automatically just go to some technological solutions and document that they're not taking their medicines? Who's going to work with patients towards actually accepting treatment as opposed to just monitoring, right? Including accepting other evidence-based treatments, like I put clozapine here as an example. You know, no technological solution, I don't think will do this. Here's my favorite philosopher. However beautiful the strategy, you should occasionally look at the results. Okay, my kids get sick hearing this from me. You know, when you know, come back with a C, you know, and then all kinds of over here and over there, and had only this not been on the test, you know, look at the results, you know. See, my standard is high, a C is not acceptable. Yeah. Failed clinical trials. Many drugs have failed, you know. Glycine reuptake inhibitors, high hopes for negative symptoms. Alpha-7 nicotinic agonists for cognition. Omega-3 fatty acids, we've talked about this here over the years, you know, for preventing people who have subtle symptoms of beginning schizophrenia to developing schizophrenia. The definite trial has failed to basically, you know, yes, it looked interesting, but when we actually do the definite trial, it doesn't work. So drug development remains a very, very important area, I think, to continue to invest in and not just give up. A lot of companies have given up at this point because it's so difficult. Having said this, there are also some things I want to end up with something to not forget. There's also the thinking outside the box. So not just dopamine and receptors, but what about, you know, targeting the microbiome? You know, this whole idea, and I really want to belabor this, is just my last slide here. The idea that, you know, maybe the bacteria in the gut play an important role in some people in modifying, you know, that environment might really be helpful. It's at the very early stages, so don't believe what you read about this. You know, we are not there yet to do this routinely or prescribe. At this point, at least in schizophrenia, we're actually only at a stage where we're simply trying to describe the microbiome, the collective kind of collection of bacteria in the gut, and not no further than that. But MGH is a place that's very interested in this because it might open up an avenue for a completely different approach to our disorders. And this is just one example. I mean, inflammation, we've had discussions here, would be another example. So thank you. We have time for a few questions.
I'll just say a lot of people had some very broad and amazingly interesting questions that were very philosophical and about policy, and hopefully we might be able to get to some of those. But I think first we can start with some things tied to the talk. So can the developments you talk about apply to other disorders, bipolar disorder, schizoaffective disorder, for example?
Yeah, one of the unfortunate aspects of drug development, or the way medicines come to market in the United States, is it has to be tied to a particular diagnosis, right? So the company has to say, well, we're studying schizophrenia, and then we're going to try to show it works in schizophrenia, and then we call this an antipsychotic. It turns out that using, you know, aripiprazole as an example, some of you might recognize, Abilify is the brand name. These are broad-spectrum psychotropics, as I call them, just like you have broad-spectrum antibiotics, right, that work for all kinds of bacteria. These medicines work for all kinds of psychiatric conditions: anxiety, depression, depression in the setting of bipolar disorder, psychosis in the setting of schizophrenia, psychosis in the setting of a delirium. So this is completely non-specific. Some of the companies, what I showed you, are actually taking the step now to talk with the FDA to say, we want this medicine approved for negative symptoms and not for schizophrenia. But it is an uphill battle at this point, and it really has hampered drug development to my mind. And it's also wrong. What you heard from Josh is that probably the disorders that we deal with in psychiatry have more in common than they are different at the genetic level, at the level of brain development. You know, the final outcome down the road might look a little bit different, and we might need to have some specific treatments for that. But broadly speaking, it's not surprising to me at all that any of those medicines that are on the market for a particular so-called indication also works for many other conditions.
Another question. So do you think, can particular medications become ineffective over time? And then sort of a related question, how would you talk about balancing between keeping symptoms in remission and keeping the dose of medication at a minimum, sort of in order to reduce side effects?
That's the art of clinical care, and that's also where patient values come in. You know, in the end, I cannot choose for a patient what level of symptoms is good for them. You know, and I think people have different answers to that. Some people tolerate no symptoms. They really always are on the quest to take more medicine in a bigger dose because they really don't want to have any symptoms. Other people that I see, they say, you know, it's fine. You know, don't worry. This medicine at this dose I can take. I feel alive. You know, I can lead my life. Even if I have symptoms occasionally, I'll manage. So it's a decision that maybe there's no app for that. Maybe it does actually require a discussion between a patient and a physician. You see, I'm a wrong generation, you know, to push the apps. What was the first part? Sorry,
the other part was, do medications become ineffective?
Oh, the ineffective. No, in broadly speaking, the answer is no. These are not medicines where we think people stop responding. Broadly speaking, you always will find exceptions to that rule, but it's not something that I worry about that it will stop working.
Okay, so people wanted you to potentially comment on a number of different treatments. So I'm just going to kind of list them, and then you can sort of decide what to focus on. I mean, people are interested in dietary treatments that could help with negative symptoms, such as folate. What you would think about that? What you think about those? TMS, psychedelics, vitamin E, its role in being protective for TD, the keto diet, and then I guess a small plug for the DreamFar program, which is a high school-based program at where people run marathons together. I don't know if you're aware of that, but it sounds great. So,
I'm all for running marathons as long as I don't have to do it. But this is exactly what's needed. Yes, I talked about drug development. I also said, you might have heard, right, that the supported exercise thing is critical. And that's where we as a society need to come together to actually offer these opportunities for people with illnesses. Very often what I see, there's actually programs out there, and then somebody comes, and then, you know, the people figure out quickly, you know, person might need a little bit more help, and they get excluded, you know, to the point that they excluded from the get-go because, you know, they say I take medicines or something. I think we need to really pay attention to this. So what about all these things that are out there that people try? You know, here's where my German background gets in the way. I'm fundamentally actually very optimistic, but I'm also realistic. If any of those treatments that you read about, if they worked, everybody would be taking them. Everybody. If vitamin E worked for tardive dyskinesia, everybody would be on vitamin E. There was some hope that it might, you know, prevent TD down the road. It's just the literature is now fairly old, hasn't been followed up on. I wouldn't bet on it, and I actually wouldn't take it. Just you know, shouldn't really use myself as an example, but the point here is, you never quite know, you know, if something might be good. This might be bad as well. So the vitamin E story, for example, and lung cancer is instructive. There's a lot of reasons why vitamin E should work to protect against lung cancer. It does all the right things with very bad molecules. And when people did the study, it turns out they actually increased your risk of lung cancer. Okay? And I think we see this all the time. Anti-inflammatory agents. I actually spoke with a few people about that. The one idea is that there's some sort of inflammation in the brain, and that has to do with schizophrenia. You know, maybe that's true. You know, maybe that's true for a small group of patients. So inflammation, let's use an anti-inflammatory agent, like aspirin. Yeah, and you know, there's some evidence, small evidence, that you can show something in clinical trials. Does this trickle down to anything meaningful clinically? I don't think so. You know, it's how research works, though. But let's not forget the following. We're making a big assumption here. We see inflammation. We want to suppress it. What if this inflammation is actually not the cause of the problem, but a response of your body to try and solve a problem? And in that case, you're actually shutting down something that the body is trying to repair. So just because some story sounds good, so I always want to caution people to think about who's selling the story. And who's selling the story are people, so science works, you know, I'm in this scientific enterprise, are people who have a vested interest for their theories to be right. Their funding hinges on it. Their publications. So always take this with a grain of salt, you know, what you hear. And over time, I think it's going to become clear what works and what not. The other questions, same with psychedelics, you know, ketamine. I mean, there's all kinds of ideas why something might be a good idea. And maybe one of those things will stand the test of time. But there's a lot of things that have fallen by the wayside over the years. Also be very skeptical. It's always the latest hobby horse in science, the latest, most exciting thing that's going to be the answer. And I've been in the field for 30 years. It has never been the answer. Maybe at some point it will. It's just a very, you know, per aspera ad astra. You know, the road to the stars is a stony one. It's a tough road. But I hope you hear from me, not that we should give up on science, not at all. That's why I'm giving this talk today. Because I do fundamentally believe that in the end, if we have a pill for lack of motivation, that's better than anything else. You know, a pill that's safe in particular. And we need to continue with that. But also, you know, I see this with a lot of, you know, people. People are hopeful about something that they read about. They spend a lot of money. A lot of money on therapies. I would not spend a penny myself. Maybe that's too pessimistic, but, you know,
No,
at least I'm honest.
That was balanced.
Balanced, thank you.
Yeah, realistic. Well, I think lastly, or you know, maybe we'll have a little more time, but a number of people had some questions about clozapine, and I know you didn't really talk that much about clozapine, but it would be great to take advantage of your expertise. One question was, which medication is a good alternative for patients who did well on clozapine but had to stop using it due to side effects? How does dose change over the years for those taking clozapine? Should doses be lessened over the years to prevent side effects? Is there an injectable for clozapine being developed? What about GI issues that are you know, associated with long-term use of clozapine? And then one person was wondering about what you thought about Abilify, because it was, I mean, this is a little bit off the clozapine thing, but it's related to the idea that Abilify was very uniquely effective for that person's family member. Anyway.
Yeah. Well, let's say this first. There's always going to be families where, based on their genetic background, they might have a very good response to one particular medicine and only one. That's why sequential trials of medicines are really important. Clozapine, as many of you know, is the most effective antipsychotic that we have. It's also the most difficult to take. It requires regular blood work. There's very serious side effects. Weight gain and diabetes are really real risks in the long run. That's why drug companies have, actually one in particular, initiated a program to develop a clozapine-like drug. I did not put this slide in because, unfortunately, their phase 3 trial, one of those trials where they show to the FDA that this drug works, showed that the drug that they were developing was good, was a good antipsychotic, but it was not effective, more effective than clozapine for the indication for treatment-resistant schizophrenia, as it's called. So it is actually remains an area of interest for drug development to develop a clozapine-like drug, a drug as effective as clozapine that's well tolerated. We'll have to see. Problem is, again, since we don't know the pathophysiology of why clozapine is better, it's really hard to develop a drug that's at least as good as clozapine. Clozapine will not be on the market ever as a long-acting injectable antipsychotic because it can cause a very serious side effect that has to do with your bone marrow, with your blood, and you need to be able to stop the medicine immediately. So you're not going to find a medicine that you give as an injectable that you cannot stop because the patient will die from if the medicine is not stopped. The other questions were a little detailed about clozapine. To my mind, it tends to work as long as you're on it. In the long run with people, the struggle is a little bit to figure out the best possible dose. This is probably the one medicine where this is the most difficult thing to figure out, how much symptoms are acceptable vis-a-vis side effects, particularly being tired all the time. And I have patients who take a fairly low dose just because they otherwise couldn't function, and yet they continue with the medicine because it's also the most effective one in this case, for the person's hallucinations. So it's an ongoing story. It's an important medicine. It's also an important medicine, I believe, and that's where some other things that I mentioned in drug development is not to find a better clozapine. If we can, great, but we need to define a system, develop a system of care that allows people to take clozapine as safely as possible. And that includes what I said, to really working with the medical system to create truly integrated systems. That's where the electronic medical record and technology actually, to my mind, potentially could come in to make a big difference for our patients.
Well, we're just about out of time, but I thought we could just talk about one policy philosophical question to end with. One person said, what can we do as audience members to raise awareness about everything we learned today? How can we put pressure on corporate leaders and lawmakers to fund mental illness research and treatment? I mean, that's obviously a big question, but...
Yeah, I think you basically, whoever answered the question, answered the question. Yeah. It is, we are here to kind of raise awareness. You've heard about it. And as hard as it is, you heard this from the panel members. What do their families actually know about schizophrenia? I don't want to criticize them because I know it's incredibly hard. All their family members more or less believe it's depression. And maybe, they actually know more than the family members might know more than the patients realize. Maybe they have ideas, but it remains very difficult to talk about psychotic disorders. Schizophrenia, it sounds bad. Nobody wants to be associated with people who might have it. So I think and we are not all heroes. I'm thinking about HIV. There were a lot of very heroic people with HIV who came forward at a time when it was not the cool thing to do to come forward that you're HIV infected, when there were no treatments. And yet it led to an enormous political movement that led to changes how the FDA approved drugs for the treatment of HIV/AIDS. So I think we have a model in HIV care how people, once they start to talk about it, once you have people who really come forward, and I think at all levels, with other families, at the legislative level, whatever position you are in, collectively, I think we would make a difference. But I do believe it's a hard thing to do. Because it remains in the shadows, even though it's an incredibly common problem. I mean, if people are honest with you, if you ask, there is almost no family, if you look far enough, that will not have somebody with a psychotic disorder because it's so common. So I think somehow getting out of the shadows collectively is going to be the answer.
Yeah, no, I thought very well put, and I would say just simply talk about it. I think that's the kind of the dumbed down version of that eloquent kind of statement. Like, we can talk about it more. Talk about it as much as you feel comfortable. But I think if we can just feel free to talk about it with anyone who we think it might be relevant for, I think that small act can do a lot. So,
Well, thank you.
thank you so much.
Thank you.
Yeah.